Okay, so let's see. Okay, I can do the recording. Okay, we're recording.
Okay. 5, 4, 3. Hello, everybody, and welcome to our panel addressing disparities, promoting equity and inclusion in clinical research. I'm Isabel Duran, the founder and executive director of the Latino Cancer Institute, a national network of Latino cancer service agencies based in San Jose, California. I'm also a member of the board at CIRM, the California Institute for Regenerative Medicine, focused on stem cell research. CIRM's mission is to accelerate stem cell treatments to patients with unmet medical needs. And in this moment and in this climate, following more than a year living with COVID oppression and all of its deadly impacts, we felt it necessary to turn the lens on diversity, equity, and inclusion. First, by CIRM doing its own navel gazing at its best practices and also asking others who work addressing disparities in research and/or care to join us this morning. Before I update you on CIRM's progress in this arena, let me introduce you to our panelists. They are Dr. Leah Dowsett, who joins us from Hawaii. She is an assistant professor of pediatrics at the John A. Burns School of Medicine at the University of Hawaii and a clinical geneticist at Hawaii Community Genetics. She serves on the Diversity, Equity, and Inclusion Committee of her hospital and is a board member of Native Hawaiian Physicians. Her primary research focuses on improving genomic health disparities in underrepresented minority populations, Native Hawaiian health, and expanding the availability of genomic sequencing and phenotypic information to her patients and families. Adrienne Shapiro is based in Southern California. She is a fourth generation of mothers in her family to have a child born with sickle cell disease, an inherited red blood disorder which occurs in about 1 of every 35 Black or African American births and leads to a host of complications over a lifetime. Her dedication to those living with sickle cell resulted in founding Access Advocacy, adding her voice to support medical trials through CIRM, lobbying for legislative support for the Sickle Cell Education Act, and bringing her passion to conferences like this. Dr. Nathan Chomolo is based in Minneapolis, Minnesota. He's an active member of multiple medical societies, including the American College of Physicians and the National Medical Association. A pediatric doctor teaching at the University of Minnesota Medical School, Dr. Chomolo was named a top doctor rising star by Minnesota's COVID vaccine health equity program. As a founding board member of Minnesota Doctors for Health Equity, working to eliminate health and health care inequities, our topic today has to be very dear to him. Welcome all. We're going to hear from you in just a few minutes. In the meantime, turning to the topic at hand, disparities, equities, and inclusion, this is how it looks from the view of one community-based organization. There are distinctions between disparity, inequality, and inequity. Disparity being the burden of illness experienced by one group relative to another. Inequality, differences in health outcomes. Inequity, systemic differences in health for a specific population that could be avoidable by reasonable means. And depending on what lens you are looking through, what does reasonable means entail? Equity assumes that everybody benefits from the same support. Equality, that is, equity, that everyone gets the support they need. And justice means the causes of the inequity are addressed. So what has CIRM done from pipeline to policy to address the issue and put its own house in order? We are attempting to feed the pipeline to ensure that potential young scientists, particularly from racial and ethnic communities, are being nurtured from high school through college. CIRM is unique in many ways. When voters approved Prop 14 in November, giving $5.5 billion, they gave us the ability to influence in every aspect of the work that we support and fund in California. That means we can fund education programs in high school and college internships that offer opportunities to students to reflect the diversity of California. Our high school and master's level programs have given more than 2,000 students a chance to get a paid internship in stem cell research. Many of these are from underserved communities. For our Spark High School program, 41% self-identified their ethnicity as Latino. When figures were broken down by self-reported race, 55% reported they are Asian and 10% Black. In our Bridges program for undergraduate or master's students, 45% are Latino, 30% are Asian. Many of these are the first in their family to go to college. 90% of graduates from Bridges are either now working in research or manufacturing or have pursued a higher degree. We are setting up affordability and accessibility working group to help ensure that when treatments are approved by the FDA, that they are available to all people of California, not just those who can afford to pay out of pocket. Our goal is simple: to ensure these treatments reach patients in need and that our work serves our diverse communities and families. We have a board that is committed to ensuring we live up to our commitments to increase DEI inside CIRM and in the work we fund. We have funded 70 clinical trials, many in rare diseases that might otherwise get no support, some that affect predominantly communities of color, such as sickle cell disease or myeloma. We are funding research into more than 40 different diseases. Of the more than 3,000 patients treated, 14% and 10% are Black. 6% are Asian Pacific Islander. When COVID struck, our board put up $5 million in emergency funding for research. Given the impact of COVID in California on communities of color, we voted a new policy to require research applicants to include strategic plans for including racial ethnic minorities in clinical trials. Today, we require every application for any research funding to have a written plan on how they will address issues of DEI. No plan, no funding. We most recently added to our Distinguished Science Review Committee, adding several scientific reviewers of color, feeding the pipeline to include scientists who see through a different lens. Our research applicants are still getting used to the idea of an inclusion plan, which asks to identify community partners from those diverse geographic areas the research will touch and with whom they will collaborate. On the other hand, our review committee is taking this requirement very seriously in their application review. And as a patient advocate on the CIRM's board, I pushed very strongly for these policy shifts in these RFPs because inclusion is not only good research, it is just, J-U-S-T, it is just research. And now to our great panel, for whom the issues of DEI are in fact very integral to their work. So I want to turn first to Dr. Chomolo, and he's going to be very gracious and kind and correct me if I said his name incorrectly. As a founding member of Minnesota Doctors for Health Equity, you recognize that there are cracks along the medical system. How does someone like yourself and the doctors who belong to your equity group show leadership to address both infrastructure and service issues?
Yeah, thanks, Yvonne, and thanks for having me here as part of this important conversation. I think, what I was really happy to hear about what CIRM is doing is the framing of looking at what is going on in your house first before trying to tell other folks exactly what they should be doing to impact things like structural racism and inequity. And so Minnesota Doctors for Health Equity really got started for me in my own journey, after Philando Castile's shooting in Minnesota over 4 years ago now, really kind of waking me up and realizing that while I was working on certain parts of health disparities, I hadn't really started to work at structural inequity and structural racism in medicine, and how the inequities we see in our systems lead to the same types of harms that we see much more acutely on the streets when police officers encounter Black and brown men and women. And so it's really from there, from the idea that, physicians are taking oaths to say, do no harm. But if we are participating in systems that perpetuate harm, then we aren't living up to that oath. And so how can that look, to your question more broadly? We've framed it a couple different ways. Physicians in general have position and privilege because of our status in society, the degrees, the 2 letters that come behind our names, that gives us access to certain conversations and tables and attention that others don't. We have power in that, and in the places that we are at, the tables that we sit at. And we have plenty, physicians, even those in primary care or research, are making well beyond the median income of your average citizen. And so how can we use that, and looking at using, once we educated ourselves on the impact of health equity and how structural racism works within medicine, how can we then take that and inform discussions at the different places we sit? So in our personal, individual lives, conversations we have in our communities, our families, even places like school boards, religious institutions, other community organizations we are part of or volunteer. How can we do it in our clinical practice, right? And so working within the clinics, healthcare systems that we are a part of, and how can we push them to not only, equity or DEI, but specifically looking at and being more anti-racist, and what does that look like? How can we use it within our medical physician organizations? So, you mentioned a couple ones. I'm part of the National Medical Association, which is the largest and oldest organization of Black physicians in the U.S. And the ACP, which is the internal medicine. I'm also part of AAP as a pediatrician. And so what are the ways we can move those large organizations to becoming more anti-racist, and what impact can that have across our communities if that was done? And then from a legislative, perspective, how can we be at the table in our city council meetings, in our state legislative meetings, talking about conversations around federal policy, and what does that look like when physicians show up to share our expertise and experience as part of the civic discussion, as we talk about being a citizen physician or citizen professional. And then what does it also look like to, recognize that we have the, really privilege of seeing folks in our communities from across the spectrum. No matter your wealth or your health, you're at some point going to talk to a physician. And so how can we take that experience and knowledge and give it to policymakers and say, this is the actual impact of the policies, or if this is your intent, here's what we are hearing from the communities you serve, more directly, particularly when we might have the time and access to those conversations that many of our patients in the communities we serve do not. So that's kind of some of like the big systems change. Well, maybe systems change isn't for you. You've kind of dedicated yourself to your craft and you feel like you're changing the world that way. I still think there's an argument to be made that you need to be really aware of structural inequity, structural racism in particular. And so, I think about things like race-based medicine and how that shows up. And so that's the idea that race can be some type of biological indicator of disease or process, instead of it being a social construct that really is just an indicator of structural opportunity and structural advantage or disadvantage, right? And we have decades now of knowledge that really kind of points to that. Yet we haven't seen the uptake amongst scientists, we haven't seen the uptake amongst clinicians to really address that and address how race-based medicine is flawed science and it's flawed medicine. And so how would, COVID-19, so I've given talks about structural racism for years, and I would, before COVID-19, end usually by saying, we just shared and you learned a lot about how structural racism leads to more morbidity, mortality for large swaths of our population. So what are you going to do now? Because if I had just presented about an infectious disease that led to large swaths of the population having this morbidity, mortality, you would be learning about that disease and how to diagnose it, how to treat it, how to prevent it, how to get the public health messaging out. These are the steps I see across the board for other parts of medicine, but we don't see that when it comes to addressing structural racism. We've seen with COVID-19 how we've moved mountains and decreased barriers to get action in place to really help prevent and treat this deadly disease. Yet we know that structural racism and inequity have the same degree of morbidity and mortality, if not greater, over decades. And so why aren't we moving with the same urgency? Why aren't we opening ourselves? Why aren't we challenging ourselves to learn more about why things like race-based medicine, for example, are actually harmful, and why are we allowing these types of narratives to persist in our discussion about how we really advance the science and health of all. And so those are some of the kind of the personal things that you could really look to address if you're not really into the whole systems change. But I would make the argument that as providers, if you took that oath to do no harm, that it's really upon us to think about how our systems potentially could do harm, and that it's not just enough to say, well, I'm just going to do my part in my little part of the area. If you're part of a system that's perpetuating harm, you need to find ways to change that.
That flows greatly into Dr. Leah Dowsett, who in fact is also a clinical geneticist. Dr. Dowsett, if you'll join us, please. What do you think is your responsibility? How far do you push against the system? And what kind of change do you think you are making or are making, as particularly around genetics and genomics, which is in many ways a very new opportunity for discovery in low-income minority communities that is not easily accessible or even understandable?
Right, exactly. A lot of what I have to do in my daily work is, translating all that information and making a lot of what's available, right, to our patients. Give me one moment. I'm going to try and share my screen and answer that question for you, Isabel.
Dowsett is speaking low because she's.
Oh, I'm sorry. Yeah.
That's okay.
Is this okay? Can you guys see it?
We can see it. Go for it.
Great. So, in talking about DE, I mean, from personal perspective, I think there has just been, a lot that I've experienced my entire life. So to help share with you guys a little bit, I wanted to show you a picture of my home. So this is a picture of where I live, and this is also where I was born and raised. For myself, I identify as Native Hawaiian, Chinese, and I'm also of Irish descent. And so I feel very tied to this land. My ancestors have been here for over 1,500 years. And in the traditional Native Hawaiian land division, it's called the ahupua'a, and it was a way to have an equitable, right, division of land, work, and resources. And so this is our ahupua'a. It's called He'eia, and this is, again, where I call home. Professionally, as I've chosen to kind of pursue a career in medicine and of course, academic medicine, there's just been, a lot of challenges, which we all have, certainly recognized and faced. And I think I just wanted to spend time talking a little bit about what role medical genetics plays. And of course, like you were saying, right, Isabel, this is a new area where we have, a lot of things that we need to translate into the community to make an impact. And so when people ask me what I do as a pediatrician and as a medical geneticist, I, kind of explain that I'm a rare disease doctor. And so I specialize in the medicine that involves the interaction between genes and our health. My work intersects with stem cell research in the realm of treatment and clinical trials that become available for patients with these rare diseases, right? Various conditions that I help diagnose on a molecular basis, right? Things like alpha thalassemia major. We have a high incidence of alpha thalassemia trait here in Hawaii due to our, diverse background of people from Asia and the Pacific. People with Duchenne's and heart disease, right? Of course, sickle cell disease, which Adrian's going to talk about shortly. Those are all things that I see. But I think, it's no surprise to anybody, right, that Hawaii is probably the most diverse state in the country. You can see that we have, the greatest number of Asians and representation amongst Native Hawaiians and other Pacific Islanders. And of course, lots of multiracial families here as well. So based on that, I think the ability to translate genomic breakthroughs to patients in a meaningful way, right, is the most imperative thing. And I think all populations really should have equal access and opportunity to benefit from a lot of the testing, right? Because in order to even get to the treatment and get to the trials and get to the place where we can start the healing, we need to actually be able to get these patients into clinic, get them seen, get them diagnosed. And so one thing that I want to talk about is, benefits of genetic testing and how that's counterbalanced with this risk of variant misclassifications. You're all, very well familiar. And it's especially true in people of underrepresented minorities that were just not well represented in genomic databases today. And that again directly translates into patient care opportunities. And so to summarize, I think we're in this genomic area, at least in my area, right, of bringing scientists and bringing other clinicians, right, to the table to kind of look at clinical research and what that means to our patients and their families. And there's just vast amounts of data out there. So I think it's my obligation to make sure that we continue to bring maximum potential of the benefits by providing diagnoses and, again, exploring stem cell-based treatments for incurable diseases in the rare disease business, and making sure that it applies to all people worldwide. Yeah.
Thank you, Dr. Dennis.
Yeah. Let me stop sharing. Good.
That's okay. Thank you very much.
No problem.
Well, you've certainly set the stage for Adrienne Shapiro, because she has learned to use her voice. Adrienne, could you join us, please? It'd be nice to see you. Thank you very much. So you've heard two very wonderful, energetic, and engaged physicians here. I saw you present at the CERN board once, and with a lot of passion and a lot of gratefulness, actually, which, sometimes when you're sitting talking to physicians, you're not grateful, you're angry. Come on, you've got to help here. But tell me about your journey and why you actually chose to step forward and become a voice for the issue of sickle cell.
Oh, thank you. Thank you for having me and for this opportunity. I have to start this by saying I am an introvert, believe it or not. And CERN was the first place that I ever spoke to a crowd of people, loudly. It was, my knees were shaking the whole time. But it has my belief in their mission and how it would affect my family is what brought me to them. Being, fourth and we believe maybe even fifth generation of mothers in my family to have a child born with sickle cell disease, I knew that science was the only way that was going to stop it. And so I had been following it very closely. And when it got to the point where it looked like CERN had broken codes and was ready for me, I called and I said, I think you're ready for me. But I think I was ready for them. My thought was at that point that stem cells would be the great equalizer. That if people could understand what the genetic code was, how people were actually made and developed, we could get past this problem of all the judgment based on skin color, education, money, those things. If we could get down and say, yes, this is it. This little thing means we're all equal. That was really naive on my part. And so I was propelled to initially follow my heart and get everybody involved into the research, right? And get Black people to be involved in clinical trials. And then as part of that journey, I ran into a young woman who had sickle cell disease and was in a community hospital. And I was told, oh, she just needs somebody to drive her home. And so I went to drive her home, and I saw the horrible conditions under which she was, I'm going to say, not being treated. And it shocked me. I'd at that time been in the medical system all my life with sickle cell, and we'd had battles, but nothing like what I saw. And I came face to face with the systemic, institutionalized racism, which for me was a shock. That you would have someone clearly in pain and needing your help, had a diagnosis, a disease that had been known for over 100 years, and yet they were receiving no treatment based on how they looked. And it it called me. It said, as a mother, you have to help. And so we formed this organization to do just stem cell, but then we realized that unless people had help at point of care, that we were going to be limiting the benefits of stem cell research to generations not yet born. And we had to get involved. We had to get involved at the policy level, at the legislative level, because we really needed changes. And what really, really spoke to me was one day I was actually in a Black Lives Matters meeting, and we were talking about the talk, right, that we give our sons about if you get stopped by a cop. So I have 3 brothers, 27 boy cousins, so I know this talk. And I realized that, so I've heard my dad give my brothers the talk, my brothers give their sons the talk, their sons are now giving their sons the talk. And I was like, wow, that's so sad. But then I realized that that was the same talk that I was giving adults who were going to the ER for care. Now, listen to what I'm saying. It's the talk if the police stop you, and the police, they have one type of job, right, to look after society. But it is the same talk when you go to the hospital, where it's the only place you can go to get the treatment that you need, and you still have to have that talk. And that talk, listen, it is, okay, speak softly, get dressed, carry all your papers with you, know your record number. If you stay in the hospitals where you know you're safe. Now imagine that. Imagine that. But that is what we go to. And it's something that a lot of people never ever think about, because Black people always know that going to the hospital is hard. And so they avoid it. But when you have sickle cell, you can't avoid it. And when all of this started bubbling up, I said, maybe this is our moment. Maybe this is our moment where our story can be heard, because you hear a lot about the children. The children are, everybody wants to save the children, but when you get 18, you're just dropped off a cliff, much like, our foster care system.
Let me ask Dr. Chomelo and Dr. Dowsett, is this the moment? I've been in so many meetings where everybody talks about infrastructure is broken. Heard some immigrant, when our work is essential, we are not. The system is we can't go back to normal, because normal never served us and it got us here in the first place. So do you see a moment here, or are we destined? Thank you, Adriana. Are we destined, and please stay with us, are we destined to always push against a system that never seems to change? So we're talking, but is anybody walking the talk for us? Changing our system, making it different. Dr. Chomelo, you could go first.
Yeah, I would say that it's maybe a little too early to know, because these systems and structures have been built over 400 plus years. So it's not going to be 1 year, one
Right.
march. It's not going to be one political election cycle, one budget cycle that we see the change undone. It's going to require, generations of effort sustained. I think we're in a moment where we can make some gains in real big systems change. And so some of my work, I work also as Medicaid medical director for the state of Minnesota, and really been trying to drive how can we better capture the impact of our policies and our budget decisions along lines of racial equity. And so that there's a process that every time we're having a new budget or new program or new policy going forward, we're looking at what is the racial equity impact projected of that policy budget. And that's a way that over time we'll be able to say, yeah, our overall budget proposal, our overall policy proposals, they were racial equity positive, racial equity negative, racial equity neutral, and be able to, really then in times when there's more and plenty and surplus, go back and hopefully invest in and continue to support communities that have been historically left behind. And then in times when there's more tightness, we have to then hopefully try to avoid and mitigate the harms and cuts. But I don't think we'll be able, again, to undo any of this, in short order. And I think it's going to require folks, having the energy and ability to continue to push themselves, it's uncomfortable because we've all been socialized to talk about race as a not like polite dinner conversation type topic, but it's everywhere, and it's really critical that we find that comfort if we're really intending on seeing change sustained.
So, Dr. Dowsett, that makes me wonder, do you feel that in fact on the science investigatory side, we're doing any shifting and changing? I mean, genomic advances and findings are very crucial in our communities as well. There are those who worry that all of this advanced medicine simply exacerbates the differences in the care and the infrastructures for communities of color. How can you make that difference?
Absolutely. I mean, I completely kind of want to echo what Dr. Chomilo has said. Again, it has been, this is a long game. Certainly now is a time where we need to kind of refocus and continue our efforts. But COVID has kind of been one of those things that have brought some of the issues that affect Native Hawaiian and Pacific Islanders to the spotlight, right? For the states in this country that do track ancestry data, we know that Native Hawaiian Pacific Islanders have the highest rates of COVID, but the lowest vaccination rates, and all of the systemic barriers that kind of go along with it, aren't unfamiliar to us. When we look at trends in the academic side, or trends in, where scientists or doctors are coming to the table, there's a recent publication including looking at Asian Americans, Native Hawaiian Pacific Islanders, and Native Americans, and Indigenous physicians comprise a very small number of the physicians here in our country. It's 0.36%. And when you look at this paper, it talks about the NIH budget, right? Things that are being dedicated to treatments, to research, to expanding genomic databases, to all of this. Over a 26-year period, only 0.17% of the NIH budgeted funds focused on AANHPI individuals, right? So, your question was about, what can we do to kind of better ourselves, better the, underrepresented minorities who have historically been left behind. And I think the answer, is kind of what you've already talked about. A lot of it's money, and putting the money right into the hands of those who need it the most, and to use the money to address those social determinants of health that will really, again, make long-term differences. In terms of genomics, I think getting minorities who have been, selected against for a really long time, a lot of the cultural trauma, a lot of the historical hate, all of that still exists. And then now getting our communities to kind of trust science, trust medicine, be willing to sign up, for genetic studies and be a part of these databases, right? It's a double-edged sword that we really need to kind of, I guess, is a delicate situation.
It's a delicate dance. Adriana, please come back. I wondered if we take Dr. Dowsett's recommendation, let's put money into it and we pour it into community-based organizations like yours. How do you help make that difference for bridging the gap for underserved communities, for under-researched communities, walking, the ethical privacy line, and then the worry about abuse in research. I mean, there are so many issues, but how does a CBO, a community-based organization, help science make the difference, help health infrastructures be better?
Well, I think
Dollars, obviously. Dollars poured in, right? You need money to do the work, right?
we need dollars. We need dollars. I think I'm going to say this first. I think we have to be willing to take risk. We have to step up and show up and speak out, but we also have to make sure our house is okay, meaning that we acknowledge what role we have as the interface between the disease community and the research community and the clinical community and the regulatory community, all of that dance that we've done historically of being nice. I say my daughter's diagnosis meant I could not be a nice girl. I could not be a nice mom anymore. And I had to do some real thinking. I mean, I'm on a committee and we're doing all this research. We're doing research on how to get more diversity in healthcare research. And right in the middle of my saying, what you ought to do, I had to say, I have to address my compliance in this. That I was raised on and told, okay, you go to school, you do this, and this is how you talk to white people. Even if you have white people in your family, you still have to learn how to talk to white people. And I thought, oh my God, this is very uncomfortable and very risky, because traditionally, you have to make nice and people fund you. Well, when you're not making nice, when you're making, as they say, good trouble, there is a cost for speaking up. And so I think the first thing you have to do is say, okay, I'm willing, recognize that. Say, I'm willing to take that risk. And you have to be realistic. So I'm talking 4 or 5 generations, hundreds of years. I know that this is going to take a long time, and I have to play the long game. And I can't do this. What's happened a lot with our culture in America is everything is transactional, right? So I'll do this and you get this, but we have to move away from that model, right? And we have to say, okay, what makes people in this country respond to things, all right? What is going to make them not look at what other countries are doing, but look at what we are doing. Look at our past. And when I say past, I mean last week, as well as what happened 300 years ago. And I think that the community-based organizations are well suited for that, right? We have to educate ourselves. We act as translators. We are harbors of trust. And I think we need to find ways to work within the system, and it sounds really funny, but not only have money, because they give a lot of money, but I was shocked at coming from a systems background where there's always checks and balances and there's always audits, and I was shocked at how little those kinds of things were in place. I was shocked at how little I could do to report what I saw as poor care. Now, I could report catastrophic care. And, if they overdosed somebody on something, or they left a sponge in on surgery or something like that. But how do you report those things which are really, really causing poor health outcomes, right? Meaning being judged. My daughter, anybody that came into her room could change her healthcare pattern by looking and saying, oh, she looks sleepy, and going back out and saying, oh, she looks sleepy, I think she's high. And then all of a sudden her pain control is gone. I think finding our own accountability, putting things in place, monitoring, and reporting is the key. And again, what is the long-term plan? It is, right, so and also looking at what's already in place and what are the things we can do for the most impact that are in the short term. For example, with sickle cell, we keep saying we need sickle cell treatments, we need to look at this, we need to and we've got all of that under care for chronically ill people. So why isn't sickle cell classified as a chronic illness? We have all those check boxes and we know why it's not, but that's something to move towards. I think checks and balances, and I think really holding people to what it is they say they're going to do. And, I think our medical system in many ways is broken because we're moved away from that concept of curing, and because we have done that and we're running it more as a business as opposed to this. And we've also put a lot of response on docs and nurses to trust their gut instinct, right? To decide whether or not to believe that patient, to then say, well, if I'm uncomfortable with whatever it is that patient is asking for, or that specialist is asking for that patient, I don't have to do that. That is really a terrible burden to place on the care provider. Can you imagine a mechanic or anything saying, okay, just go with your gut, fix my car? So I think that's where we have to move, and it's going to take decades.
So I would
Go
just,
ahead.
if all right, I agree with 99.9%.
I'll take good. I'll take it.
I mean, and it's just more framing because what I say is the systems aren't broken. They are actually getting the outcomes they are designed for.
Exactly.
And so what you like talking about a business model, we live in a capitalistic, a racially capitalized society that is going to get then a healthcare system that is looking at the bottom line. And so even when we look at how we're trying to address health equity, it's always done in this kind of return on investment. I will do efforts and stand up or programs that then show me that you save me money, not just demonstrate that it actually is the same amount of money but better health, right? So I think that is like a key distinction that we I think helps move the conversation along and kind of builds to what I try to have folks understand is that we need to actually think about not just what we can do and how we can be part of the solution, but we need to start thinking more and more about how we're part of the problem. We need to think about what we need to learn, but what are the things we need to unlearn that we've been taught about our systems and how they deliver care and about what it means to be a physician or be a scientist in these systems. And to kind of to Dr. Leah's point, I think when you look at things like how research is funded, we really need to try to think about ways that folks can make the right decision, the easy decision, and so that they aren't like finding ways to fund health equity or addressing racial equity, through all these different other pathways and streams. When I look at NIHS grants, their grants, even around health equity, don't actually require any type of equity assessment or of impact, right? And so that would be like a real easy, basic place to start, is that if you're going to do research and you're going to be one of the main funders of that type of research in the world, that you start thinking about requiring your researchers and their PIs to have that level of analysis, which inherently then leads to working with community-based organizations. And I think community-based organizations really are the crutch here for helping us learn and unlearn and helping us design systems that make the right choice, the easy choice.
Dr. Dowsett, I'm going to give you the last word, but thank you, Dr. Chomelo, for reminding me that it is, in fact, systems aren't broken. It's what we have to do. They have to change to serve the patient, not the bottom line, if I'm not mistaken. So, Dr. Dowsett, in genetics, I mean, I think of it as preventative care. If you catch things early, you can address them early and you don't end up with a third stage, fourth stage killing tumor where you can do fancy, advanced genomic or genetic testing, etc. So I'm very curious based on all of this. Do you see the model as well, working with community-based organizations as integral to helping shape and reshape what systems do to work for communities and for people and for quality care, as opposed to serving the bottom line?
Oh, absolutely. I mean, I think getting community buy-in, at least from a cultural perspective here in Hawaii, makes perfect sense. It's really important, right, in terms of our competency, and of course, a lot of the mistrust that exists from the way that our system has been set up over time, and not really working for people who are of minority descent. I think in terms of moving forward and trying to use genomics, right, like this cutting edge technology, and what that's going to look like in terms of bringing stem cell research to our patients with these rare diseases. It's going to, of course, have to take community buy-in, because again, we need parity. We need parity across the field, right? It's not just we need more parity, at the higher levels and the administrative levels, at a national level. We need parity to get more Indigenous people into medical school so that they can provide competent care, but also at the community level, we need more engagement, and we need to help make these systemic racial issues, we have to bring them to light so we can help them disappear.
That's it.
So
Perfect.
I said you had the last word, but I've got 5 minutes left. So so I'm really excited because you all are there, because you're all making differences and using your voices, though you might sometimes feel frustration that am I or am I not making a difference? How will you each, the end of your week, the end of your month, look at yourself and say, I did make a difference, I moved the dime, and what would that look like? So let's start with you, Dr. Nelson. Yeah.
Sure. I love the work that I do. I'm very passionate about taking care of patients and families. In my field in genetics, we're not just taking care of one patient, but we're taking care of many generations of families. And I think that's, really, really gratifying. But also, too, I think a lot of it goes back to giving back beyond the community, but also like helping that next generation. So through my mentorship of other students, medical students, people of all levels, undergraduates, I'm, trying to encourage, underrepresented minorities to even consider, medicine or, becoming a scientist as a career. And I think, that's probably, again, as a doctor, I feel like what I do is also, is being a teacher. And I think that's also, where I'm going to kind of think about as the end game moving forward, right? Getting more people to kind of buy in and continue on the work that's so needed.
Dr. Chomila.
Yeah, I think mentorship is a great example, and and reflecting quickly here, if you would have asked this maybe 5-10 years ago, I would have said, well, it's probably looking at publications and awards and those type of things, and doing the work I've found very necessary and helpful internally and personally. I think it's really going to be, and what I hold up as, what's my impact on my community when I go to church, when I go to the barbershop, when I have conversations with family, or at community events, am I the same there as I am in these spaces, and am I kind of helping them, the impact on those folks close and near and dear to me, are they seeing the impact? And so I think that's the guiding light that I try to find and follow, and hope that it trickles out that way.
Adrian, one of the things I did hear from you on that same theme, though, is sometimes it's a lonely place to be when you're using your voice, but does it give a sense of I want to say pleasure at the end of the day that you stood up I mean, you know, that you used your voice, that you did what you could.
Oh, absolutely. Absolutely. I always tell people my mother used to take me to prayer meetings where they would pray over my brother, and then we'd go out. And when she'd get me by myself, she said, God is good, but science is going to fix this. And I'm a true believer of that. And so I think for me, it's like even at the end of the day, when now that my daughter is on a new treatment and her life has really changed, and I don't have to go and make sure she's breathing every day and every morning, the more people and the more other mothers that can have that experience and share that with me. And then I look, my North Star are our bubble babies, because I've been with them when the moms had them completely isolated, and then they've had their transplants. And we saw one of them, she dropped something on the floor, and all the moms were kind of around, and she went to pick it up. And we all started to run towards her to stop her. And then we realized we didn't have to. And so for me, that's it. That's it. It is stopping what's happened for generations and what's happened to us culturally as Black people is now a quantifiable disease, and we're going to have to fight that as well as we're fighting for our specific diseases.
Well, thank you all very much. All very inspiring. We appreciate the work that you are doing. Each and every one of you does make a difference. We're glad to always have the patient voice. It is more crucial than anybody knows or believes. And so, thank you, Adrienne, for your work,
Thank you.
because telling the community how important their voice is and how it can make a difference in their life and that of the community, I think is one of the most important gospels that you can preach and teach. It is really crucial for communities to know that they, in fact, have power. They
Yeah,
just have to learn how to activate it. And we wonderful to have partners in science and in medicine
absolutely.
who also can see through those lenses and are very active in helping us move forward in all of the work that we have to do. So thank you all very much for joining us, and thank you very much to all of the participants who spent their time with us today. I hope you have a rest of a very great conference. Thank you to Adrienne Shapiro, Dr. Nathan Shomelo, and Alea Dosen. Sorry, and we'll see you hopefully again sometime doing
Good
good
work.
work out there amongst your peers. Thank you
Thank
very
you.
much. Goodbye.
Thank you.
Thank
Thank
you.
you so much for the opportunity.
Thank you.